objectives are to review very briefly transitional circulatory physiology and the clinical assessment of infants with suspected pulmonary hypertension. And then I hope to spend a little time having you think carefully about our current approach to therapy. And at the very end, I'll explore some translational opportunities that I think are on the horizon with some therapies that are under investigation. So we'll start out with this picture of the fetal circulation, because to really understand pulmonary hypertension, you have to understand the circulatory pattern before birth. So transitional circulatory physiology is perhaps the most dramatic event in human biology. This is the process that converts the high pulmonary vascular resistance that normally is the in utero state to the low pulmonary vascular resistance that is necessary after birth for normal gas exchange and survival. So as you all know, the fetal circulation is characterized by three unique structures: the ductus venosus that connects the umbilical vein to the inferior vena cava, the foramen ovale that connects the right and left atria, and the ductus arteriosus that connects the main pulmonary artery to the aorta. And the high pulmonary vascular resistance of the fetus is really supported by the relative hypoxemia of the in utero environment, where the oxygen saturation in the umbilical vein, which is the highest, the vessel with the highest PO2, is about 80%, and that in the descending aorta is about 58%, with a PO2 that's between 15 and 20 millimeters of mercury. So the fetus is well accommodated to a hypoxemic environment. So what happens at birth? So this could be a talk for an hour itself. I've distilled it down to one slide and 5 points, because I know this is a sophisticated audience. So with the first breaths of life, fetal lung fluid is cleared, a functional residual capacity is established, and surfactant is secreted. Coincident with clamping the umbilical cord, that low resistance placenta is removed, and systemic vascular resistance rises. The rise in PO2 causes release of a number of vasoactive mediators, including nitric oxide, resulting in a fall in pulmonary vascular resistance and an increase, 8 to 10-fold increase, in pulmonary blood flow. That increase in pulmonary blood flow, of course, results in an increase in pulmonary venous return to the left atria. This increases left atrial pressure and functionally will close the foramen ovale. And lastly, the increase in pulmonary blood flow, as well as the increase in PO2, will decrease ductal level shunting. And voila, you have transitional circulatory physiology, if all goes according to plan. But as we know, not every baby makes this transition easily or well. And those who have the condition we call now persistent pulmonary hypertension of the newborn have a failure to achieve or sustain the normal decrease in pulmonary vascular resistance at birth. This is characterized by altered pulmonary vascular tone, altered vasoreactivity, and sometimes, in some infants, altered pulmonary vascular structure. These infants have severe hypoxemia as a result of right to left shunting across the ductus arteriosus and the foramen ovale. And unlike pulmonary hypertension in adults, this is a pretty common condition, a common reason for infants to be admitted to neonatal intensive care. It occurs in 1 to 2 per 1,000 live births, and even in today's era of inhaled nitric oxide and ECMO in some of our units, it still carries a significant mortality. So how do you diagnose PPHN? The answer is you have to first have a degree of suspicion for this condition. So anytime you have an infant in your nursery whose hypoxemia is disproportional to their degree of lung disease, you should think of pulmonary hypertension. Of course, some of these infants can have significant lung disease. For those of us who still do physical exams and not just call the cardiologist or call our excellent echocardiographers, if you listen carefully, you can hear a single second heart sound. Why is that? Because the normal splitting of S2 is due to the relative difference between systemic and pulmonary vascular resistance in postnatal conditions. When your pulmonary vascular resistance and your systemic vascular resistance is equal, you don't get the normal splitting. So if you listen carefully, you'll hear a single-second heart sound. You may also notice a differential in pre- and postductal saturations. And in neonatology, it is always advisable when you are worried about PPHN to put an oximeter on the right wrist and on a leg, making sure you have a pre- and postductal location. But if you do not see a differential of 5 to 10% in pre- versus postductal saturations, that doesn't really rule out pulmonary hypertension. What it does rule out is a ductal level shunt. You could still be shunting at the atrial level or just have right heart failure. The poor man's echo is the hyperoxia test, where you put the baby in 100% oxygen for 5 to 10 minutes, not for hours. And if your PO2 goes above 150, you can pretty much rule out cyanotic congenital heart disease. But if your PO2 does not rise dramatically with 100% oxygen, you really are not helped very much by this test, because a PO2 less than 150 really can't rule out congenital heart disease or PPHN. And so the gold standard is indeed 2D echocardiography with color flow Doppler, representing, you can see a Mac to PC problem. That should be an arrow, a right to left shunt at the level of the atria or the ductus arteriosus. So this is the Aschner AABC assessment of an infant with PPHN. It's very simple. Remember to think about airway patency and alveolar recruitment, always taking into account what you think is the underlying lung pathology. I think we all do that when we have an infant that we are concerned might have pulmonary hypertension. But failure to recruit lung is one reason why our therapies, our vasodilator therapies, sometimes fail. And we'll get back to that in a minute. Always think about blood flow, both the degree and the level of shunt with your echocardiography. But the most important point I want to make with this slide is to not forget the C. Think about your cardiac output. Think about filling volumes. Maybe the tank isn't full. Assess contractility, as we just heard, and think about structural abnormalities. I think the reason why those infants who fail to respond to our medical management and our vasodilator therapies fail is because we forget to assess their cardiac output. So this is a very old slide. I think the percentages may have changed over time, but the point is still valid. PPHN is not a disease. It's a clinical syndrome associated with many diverse diseases. And so it's really not surprising that no single therapy is effective in all infants. So I'm going to be talking about a number of therapies, both proven and some that are still experimental, for treating infants with pulmonary hypertension. So my first question with a raise of hands is, how many of you do not have the availability of inhaled nitric oxide in your nursery? A few. But the majority of you do. Okay. So I'm going to go relatively quickly. Were there more? How many people do not, again, how many do not have inhaled nitric oxide, just so I have a sense of it? Okay. So I'm going to review some of the older data. It really goes back to the early 90s, upon which the approval of nitric oxide was based. I'm going to do it rapidly because I know you're all familiar with the data. But we'll start out with this cartoon, very, very simplified, of the nitric oxide cyclic GMP pathway, in which the substrate, the amino acid L-arginine, is converted by the enzyme nitric oxide synthase, of which there are 3 isoforms, to another amino acid, L-citrulline, and nitric oxide, a free radical. NO then acts on soluble guanylate cyclase to increase the second messenger, cyclic GMP, which either directly through its action on ion channels or indirectly through G kinase mediate vasodilatation. So there were a number of studies that were done in the United States in the early part of the 1990s, and then followed with some studies from Europe. And this is an old meta-analysis that Reese Clark did, looking at the major studies. You can see that the the study designs differed from trial to trial. This is a problem for us in neonatology. We never seem to do the same study twice, so putting together meta-analyses becomes quite problematic. But you can see that the range of doses was between 20 and 80 parts per million. The approval of this drug was really driven by the largest of the trials, Reese-Clark's Synergy trial. There was a range of duration of therapy, and only the OMETA trial did not allow adjunctive therapies, such as high-frequency ventilation and surfactant, and it was the reason why that trial was stopped early. So this summarizes the individual results of these studies and then the total with 538 infants. And you can see, other than the OMETA trial that was stopped early and did not have the power necessary, all the other studies and the combined analysis, including this trial, showed that the relative risk of going on to receive ECMO was significantly reduced in those babies that received inhaled nitric oxide versus placebo. But there was no difference in the likelihood of death as long as ECMO was available as a rescue therapy. So how many of you have access to ECMO in your nursery? Not very many. Okay. So I'd like to point out some things. There are some missing data from the literature. And so these data I'm going to show you are not the best way to go about answering a question about a dose response for nitric oxide, but it's as good as we've got, because nobody has done that dose response randomized control trial. But the point here is that the response rate by maximum dose of NO does not follow a dose response relationship. As a matter of fact, the best responses were down here at the lowest doses, and ever increasing amounts of nitric oxide did not improve the likelihood that the baby would respond with an improvement in oxygenation or that the baby would survive without ECMO. Now again, this represents those infants out here are infants who failed to respond to lower doses. And so be careful with the interpretation of these data, but they are the best data we have. But even though there is no evidence that more is better in terms of efficacy for inhaled nitric oxide, there's a lot of evidence that high concentrations, 80 parts per million, is associated with toxicity. And so these are methemoglobin levels in control infants receiving no nitric oxide, those receiving 5 and 20 parts per million with no difference down here, and then a large increase in methemoglobin percentage in those infants receiving 80 parts per million. And this curve looks very similar to the levels of nitrogen dioxide. So again, the take-home message here is that there is no evidence that more than 20 parts per million is efficacious, and a lot of evidence that it may be associated with some adverse effects. So this trial that was published by John Kinsella in 1997 was not included in that meta-analysis that I showed you. But this is a very interesting study, and I want to spend a minute talking about it. So what they did in this trial, it was a multi-center study, was randomize infants to receive inhaled nitric oxide in one arm or high-frequency oscillatory ventilation in the other arm. Infants who failed to respond to the initial randomization could cross over to the other arm, and if that failed, they could get both therapies together. And John published this slide, or these data, and I want to walk you through it because it has some very important points in terms of how you should go about treating your babies. So first I want you to look at these two middle groups, meconium aspiration syndrome and respiratory distress syndrome. These are two groups of diseases that are both, so by definition, all these babies have pulmonary hypertension. But in these two groups of infants, there is also a significant pulmonary component to their disease. And in that case, when there is both a pulmonary component and a vascular component to their lung disease, the combination of high-frequency oscillatory ventilation to improve lung recruitment and a vasodilator therapy with inhaled nitric oxide was synergistic, more effective than either therapy alone. Idiopathic pulmonary hypertension refers to those infants with no parenchymal lung disease, sort of black lung pulmonary hypertension. We've all seen those infants. Their lungs look clear, but they have wicked PPHN. And in that case, HFOV was not particularly effective. These infants did not have small lung volumes. Inhaled nitric oxide was relatively effective, and the combination was no more effective than vasodilator therapy alone. And then, of course, here are our babies with congenital diaphragmatic hernia who don't care what we do. They don't respond sometimes to anything. So to summarize, these are the recommendations that have been approved for the use of inhaled nitric oxide, and is the approach that I think most nurseries in the US and in Europe use. So who can be treated? This therapy is really only approved for term and close to term babies greater than 34 weeks, with an oxygenation index greater than 25, so modestly ill, and echocardiographic evidence of adequate cardiac output and right to left shunt. The starting dose is 20 parts per million. The maximum dose is 20 parts per million. And in most infants, you can reduce rapidly down to 5 parts per million in the first 4 to 24 hours. Most infants who are going to respond will be treated for less than 5 days. The exception is those babies with congenital diaphragmatic hernia who maybe we shouldn't treat at all, but we often do. Weaning involves a decrease to 5 parts per million, again, in the first 4 to 24 hours, and then a slower decrease from 5 to 4 to 3 to 2 to 1 part per million before discontinuing. At that point, when the FiO2 is less than 0.6 and the PaO2 is greater than 60 for about a half an hour to an hour on 1 part per million, we generally increase the FiO2 by 10 to 15% before discontinuing inhaled nitric oxide and observing for rebound pulmonary hypertension, which very commonly occurs. So the subtleties of using inhaled nitric oxide, including being aware of this rebound phenomenon, and I'm going to talk a little bit more about that in a few minutes, and to remember that getting worse, rebound pulmonary hypertension, when you turn off the nitric, can occur in those infants who didn't get better when you started nitric. So even non-responders can have rebound pulmonary hypertension. And this really does have implications for using nitric in a non-ECMO center when ECMO is available after transport. You need to be sure if you're going to start it that you can transport that baby on nitric, because they may get worse when you turn it off, even if they didn't get better when you started inhaled NO. The second big take-home message is that poor lung inflation with inadequate alveolar recruitment is probably the most common cause of treatment failure. So that HFOV or surfactant therapy or increasing your PEEP, some maneuver that you have available to you to improve lung inflation, combined with the vasodilator therapy, in this case inhaled nitric oxide, is more likely to result in a better outcome for infants with parenchymal lung disease than using nitric oxide alone. And, as I'll show you on the next slide, surfactant did reduce the use of ECMO in babies with parenchymal lung disease, but not babies with idiopathic PPHN. So there have been a couple of studies, this is the largest of them, looking at surfactant for term respiratory failure. This was a study in 338 infants that had meconium aspiration, sepsis, and pulmonary hypertension, who were randomized to Cervanta in this particular case, or no Cervanta. And the results of this study was Cervanta group needed less ECMO, 29% versus 40%, so statistically significant, with the largest effect in those infants with milder disease, an oxygenation index of 15 to 22. Again, re-emphasizing the point that you can't just address the pulmonary vascular disease. You need to think about the underlying lung physiology, and if the baby has parenchymal lung disease, use what therapies you have available to you to improve volume recruitment of the lung. So with the next part of my talk, I'm going to talk about something that everybody just assumes is the right thing to do, which is oxygen therapy for PPHN. So this is not surprising. We know that PO2 is an important determinant of pulmonary vascular resistance, and indeed it is the breathing of room air and the increase in PO2 at birth that results in the dramatic fall under normal circumstances of PVR. And so, from time immemorial, supplemental oxygen has been the mainstay of therapy for hypoxemic respiratory failure and PPHN. And there are really good data that support avoiding hypoxemia. But I suggest that the optimal target range for PO2 in babies with PPHN, or anything else for that matter, is unknown. So this is a really old but totally classic paper published in 1966. Abe Rudolph was the first author. He was a young man then. And this shows the relationship between mean pulmonary artery pressure and PO2. And you can see there is a very steep relationship between these two parameters. But if you look at these data carefully, and these were data in newborn calves, you will see that the inflection point for the increase in pulmonary artery pressure occurs at a really low PO2, down here in kind of in utero PO2 levels, below 40 millimeters of mercury. And I'm sorry, I'm using US terms. You can hopefully do that translation better than I can. The relationship is totally flat out here at PO2s where most of our babies live and where we are comfortable. Anything above about 50 millimeters of mercury, there's really not much relationship between mean pulmonary artery pressure and PO2. So how did we get where we are with oxygen therapy? So in the pre-inhaled nitric oxide era, which is when I trained, supraphysiologic PO2 targets were common. And that's because we neonatologists had a preference for weaning ventilator settings over FiO2. Those were the days with not very sophisticated ventilators, no synchronization. We use long eye times. We put chest tubes in all day long in these babies with meconium aspiration and pulmonary hypertension. So getting ventilator settings down was really important. And we had a really complacent attitude about the tolerance of neonates for hyperoxia. I remember being told by my attending physician when I was a fellow about putting rabbits in 100% oxygen. If you put an adult rabbit in 100% oxygen, it'll die in a couple of days. You put a newborn rabbit in 100% oxygen, and those rabbits can live for a couple of weeks in high FiO2. It doesn't mean that it's good for them, however. And then, of course, there was no ECMO, there was no inhaled nitric oxide, and we had this terrible fear of labile pulmonary hypertension and acute life-threatening hypoxic pulmonary vasoconstriction. For good reason. These babies would just die before our eyes, and I lost many of them in those early days in the NICU. But I think in the current era, there's a growing appreciation for the potential injurious effects of hyperoxia and reactive oxygen-induced damage. So I'd like to share some studies with you that came mostly from the group in Buffalo and in Northwestern, Robin Steinhorn and Satyan Lakshminrumshima's, I always say his name wrong, laboratory. These are studies that were done in newborn labs. So this study was done by taking normal term newborn lambs and exposing them for either 30 minutes or for 24 hours to room air or to 100% oxygen. And then they sacrificed the animals. They removed their small pulmonary arteries and hung them in a tension bath and measured the contractility of these small pulmonary arteries. They were all in the same PO2 environment during this study. And what this shows is that whether you are exposed to 100% oxygen for 30 minutes or 24 hours, your blood vessels, your pulmonary blood vessels, are far more vasoactive when exposed to increasing doses of the endogenous catecholamine norepinephrine, a vasoconstrictor in the lungs. And so you can see that compared to the room air group, both of these arteries who were exposed, sometimes for a very short period of time previously, to 100% oxygen are much more contractile, much more likely to constrict. They followed this study with another one, published in 2007, in which they took newborn lambs. This is an in vivo study. They raised their pulmonary vascular resistance with U46619. And these lambs likewise were exposed for 30 minutes only to either room air, 50% oxygen, or 100% oxygen. All of these studies were then done to keep the PO2 between 45 and 60 in the same environment. And then they exposed these lambs to 20 parts per million inhaled nitric oxide. And what you can see is compared to the room air, or 50% group, the group of lambs who saw 100% oxygen for 30 minutes before the study was done had a blunted dilator response to inhaled nitric oxide. And when they turned the inhaled nitric oxide off, pulmonary vascular resistance in the room air group and in the 50% oxygen group went back to baseline. The lambs that saw 100% oxygen for 30 minutes had what we would call in the nursery rebound pulmonary hypertension, where their pulmonary vascular resistance went much higher than it started out at baseline in the presence of the thromboxane mimetic U46619. So it makes one wonder whether the way in which we are treating our infants in the delivery room or right from the beginning with 100% oxygen isn't setting up some of our babies for failure to respond to inhaled nitric oxide. Satyan also published this study in 2009 in which he looked at pulmonary blood flow in control lambs where they have no PPHN and they had a beautiful increase in pulmonary blood flow over time after birth, or lambs who had in utero ductal ligation, a model of PPHN, and then were ventilated with either room air, 50% or 100% oxygen. And you can see these lambs are in trouble. In the absence of inhaled nitric oxide, they have pretty low pulmonary blood flow. It increases slowly after birth, but nowhere near the normal control lambs. But there's no difference in pulmonary blood flow in the lambs treated with room air versus 50% oxygen versus 100% oxygen. So yes, they have pulmonary hypertension, but the FiO2 did not make a difference in their improvement in pulmonary blood flow. So what should we neonatologists do about the FiO2? And I don't have all the answers, but I am increasingly worried about our aggressive use of oxygen in this population. I think we should indeed avoid both hyperoxia and hypoxia because, as the data show, there's little further improvement in pulmonary vascular resistance or pulmonary blood flow once your PO2 goes above about 60 millimeters of mercury. And it also suggests, for those of us who have inhaled nitric oxide, that we might be better off weaning the FiO2 before weaning the nitric oxide, even though it's expensive. And so I think this quote applies pretty nicely to the oxygen story. Experience is a hard teacher because she gives the test first and the lessons afterwards. And this quote by Einstein, the significant problems we face cannot be solved at the same level we were at when we created them. So this is my transition to some novel therapies, and I'm going to show you some research that's coming out of some laboratories, others as well as mine. And my disclosure is that the therapies discussed during the remainder of this presentation are unproven and unapproved by any regulatory body, and they should not be used in human infants except as part of a clinical study with informed parental consent. Okay? Even though it's tempting. So I distilled a huge amount of work that's been done by Kathy Farrow and published in Circulation Research and many other journals, looking at the fact that babies with PPHN, in her case they're lambs with PPHN, or conditions of hyperoxia, and I'll show you some studies from our laboratory with hypoxia, have an excess of free radicals. Okay? And that some of the vascular dysfunction that we see in pulmonary hypertension is due to oxidant stress and alterations in signaling processes due to an excess of free radical production. So this was a study, again, that the Steinhorn and Buffalo group did, looking at the effect of human recombinant SOD and nitric oxide on oxygenation in lambs with pulmonary hypertension. So I'm sorry that's small. I'll walk you through it, though. Again, this is the in utero ductal ligation model of PPHN. And so these lambs with PPHN are incredibly sick, and under control conditions, which is this bottom line, this is control, they have very poor AA ratio. They are poorly oxygenated. And these two little arrows are two lambs that died before they got to the end of the 24-hour study. What you see on these upper graphs, and they're all pretty superimposable, is treatment with inhaled nitric oxide causes a nice improvement in oxygenation. Treatment with SOD, superoxide dismutase, also causes a nice increase in oxygenation. And even if they delay the start of SOD therapy, which was given one dose intratracheally for 4 hours, so more like the clinical scenario in which we might use it, here is 4 hours of poor oxygenation. Now at 4 hours, intratracheal SOD is given, and marked improvement in oxygenation. They also published this study in which they gave the combination of inhaled nitric oxide and SOD. And compared to NO alone, they got a marked synergistic effect. This is not surprising because we know that free radicals inactivate inhaled nitric oxide. Superoxide and nitric oxide, they have high affinity for one another and produce peroxynitrite, which is a very toxic substance. And so, again, I think this is a therapy on the horizon and one that needs a lot more verification, both in animal models and, of course, human trials, but is a very attractive therapy in the future for babies who are either failing to respond adequately to nitric oxide or in those countries where inhaled NO is not available. All right, back to the nitric oxide cyclic GMP pathway. And I promised Tom I was not going to talk about sildenafil. That is going to be his job. And so we are not going to talk about the PDE5 inhibition as a means to increase cyclic GMP. But remember that arginine is a substrate for the production of NO from NOS. And this, too, if you gave excess substrate, might possibly be able to drive this reaction forward. So what's the problem with that concept? Well, some, but not all studies have shown beneficial effects of L-arginine in human and experimental pulmonary hypertension. And there's a concept well described in the literature known as the arginine paradox. And what the arginine paradox tells us is that there's lots of arginine inside our cells, way in excess of the Km for nitric oxide synthase. So limitation of arginine as a substrate should not be a cause of inadequate NO production. And yet there are many studies that show, particularly cellular studies, that you can increase NO production by giving arginine. So people have come up with explanations for this paradox. One explanation that's possible is overcoming endogenous antagonists of nitric oxide synthase, such as asymmetrical dimethyl arginine, which is endogenously produced in patients with pulmonary hypertension. Another explanation, and one that I favor, and I'll show you some data, is that even though there's lots of arginine in the cell, there's limited availability of that arginine in the cell microdomain where eNOS is present and where the arginine needs to be delivered to make nitric oxide. Nonetheless, the idea of giving something like arginine is very attractive because it can be given orally, it can be given IV, it's very inexpensive, we have lots of experience in children with inborn errors of metabolism using arginine. The problem, however, is that oral arginine is inactivated by hepatic arginase. Even IV arginine is inactivated. So that brings me to the urea cycle. So you may be wondering why, in a talk on pulmonary hypertension, I am now going to show you a hepatocyte and the urea cycle. So back to medical school and your biology. The rate-limiting enzyme of the urea cycle, the enzyme that converts ammonia to carbonyl phosphate, is an enzyme called CPS1. Carbonyl phosphate and ornithine combined through the enzyme OTC to make citrulline here in the mitochondria of the hepatocyte. Citrulline is then exported into the cytoplasm where it is converted by two enzymes, argininosuccinate synthase and argininosuccinate lyase. That's the last time I'm going to say that. I'm going to call them ASS and ASL. Citrulline is converted to argininosuccinate and then to arginine, which if you are a liver cell, will be converted by arginase to urea and ornithine, and you've got the urea cycle. But there are many, many cells in our body that have the lower part of the urea cycle enzymes, particularly ASS and ASL, present, and theoretically can convert this arginine produced from citrulline to NO plus more citrulline by nitric oxide synthase. So what do we know about urea cycle function in our babies? Well, we know that urea cycle enzymes first appear very early in gestation, between 13 to 18 weeks, and their expression and activity increase gradually till term. But even full-term babies have less than 50% of their adult urea cycle capacity. And biochemical immaturity is even more pronounced in our premature babies. The other thing we know is that lack of nitrogen delivery to the gut limits the endogenous production of arginine and citrulline. The small intestine and the kidney produce most of the arginine and citrulline that's exported to the general circulation. The liver just uses it for the urea cycle to get rid of ammonia. And they use both endogenous and dietary nitrogen to do this. This accounts for the very low levels of arginine and citrulline that are measurable in term infants, they are very low, as well as the higher ammonia levels that we're used to seeing in our babies. So this is a slide that I just stole from Bill Hay this weekend. It was actually published in 2003. It's a nutrition study where they looked at babies who are on 1 gram versus 3 grams of amino acids. Now, all I want to show you over here is that we don't give our babies any citrulline. There's almost none in our TPN, and even on 3 grams of trophamine, they have very, very low levels of citrulline. So as I mentioned, the expression of these lower urea cycle enzymes are tissue specific. So in the liver, arginine is converted to urea and ornithine by arginase. But in many other cells in our body, including our endothelial cells, we think that citrulline is converted to arginine, which can be used by nitric oxide synthase to produce NO. So how do we prove this theory? Well, if we were able to knock down ASL, we would expect low arginine levels in the cell, and we asked, under those circumstances, what would happen to NO production? And so I'm going to show you some work from our laboratory that I think has great translational potential. So we teamed up with a group from Baylor who were a bunch of geneticists who had a mouse model, a hypomorphic mouse model, where they knocked down the enzyme ASL. And this is a model of a human inborn error of metabolism. We've taken care of babies with this disease. It's called argininosuccinic aciduria, or ASA. And you can see this mouse has a very shortened lifespan. They die at 3 to 4 weeks of age. If you completely knock out ASL, it's lethal. The mice die within 24 hours of hyperammonemia, just like our babies with this condition die. And of course, they have a nice phenotype. They don't grow well, and they have a funny coat. 2 years of work, I'm not kidding, 2 years of work. This paper was finally published in Nature Medicine. I'm only going to take you through a couple of the figures. There's hundreds of them. So we found that in this model where you knock down ASL, there's low messenger RNA for ASL, as you would expect. There's low protein expression of ASL, but ASS and eNOS are normally expressed. And the activity of this enzyme is about 15 to 20% of normal. Also, biochemically, we saw exactly what we would expect. If you have little ASL, you would have increased upstream of ASL citrulline, increased ASA. Matter of fact, ASA is so fleetingly present, it's so metabolized rapidly by ASL, you can't measure it in the wild type, but we were able to measure it in the hypomorph, and low levels downstream of arginine. This mouse had evidence of reduced nitric oxide production, NO deficiency, and evidence of NOS uncoupling and free radical excess. So the nitric oxide synthase gene must be coupled to make NO. If it's uncoupled, it makes superoxide instead of nitric oxide. And there were multiple ways in which we looked at this. We saw less NOS dimerization. Normally, NOS occurs as a dimer. If it's a monomer, it's uncoupled. Increased urinary isoprostanes in these animals. So evidence, again, of free radical disease. Oxidative stress causes an increase in isoprostanes. Reduced tissue nitrosylation, and the animals were hypertensive. I tried to measure pulmonary hypertension in these little mice. I couldn't do it. But we did look at vasoreactivity in this model. So under normal conditions in the wild type, if you constrict with phenylephrine, you get vasodilation quite nicely with a low dose of acetylcholine, an NO-dependent vasodilator. In the hypomorph, even 300-fold more acetylcholine failed to cause any vasodilatation, but these aortas were able to dilate normally to an NO donor. And in the humans with ASA deficiency, they also had failure of flow-mediated vasodilation. So we developed a model for molecular channeling of citrulline and arginine to nitric oxide synthase, where we believe that the citrulline gets delivered to ASS, this enzyme, and then produces ASA, which gets converted by ASL to arginine, and then gets acted upon by nitric oxide synthase to produce NO and citrulline. And that all of this needs to occur in a complex together in a very specific location in the cell, in the caveoli. So this would suggest, this model, first of all, would explain the arginine paradox, that the arginine in the rest of the cell is not really available for NO production. And it would also suggest that citrulline might be an effective precursor for NO production. And citrulline is an arginase-resistant precursor of arginine. So we did a study, it's unpublished at the moment, in adult humans where we gave them oral citrulline or oral arginine and measured the arginine in their blood. And you can see that citrulline was more effective than arginine in increasing arginine levels. So in humans, citrulline is converted to arginine. Citrulline also increases phosphorylation of eNOS on serine 1177, which is important for activation of the enzyme. And citrulline recouples eNOS in hypoxic pulmonary arteries. So here's a therapy, potentially cheap, easy to deliver, one we have long experience with because babies with inborn errors of metabolism get treated with citrulline, that recouples NOS, increases the production of arginine, and I'll show you some data to suggest that it might just be effective in several models of pulmonary hypertension. So the first model is a newborn piglet model of pulmonary hypertension that's produced by taking newborn pigs and putting them in hypoxia. And these 2-day-old pigs are raised in either normoxia or hypoxia for 10 days. This is my longtime collaborator, Candace Fike. And once the animals have developed wicked pulmonary hypertension after 10 days of hypoxia, they're sacrificed and a number of measurements are made, including exhaled NO measurements from isolated perfused lungs and measurements of NO production from the vasculature. And what we showed is if you treat these hypoxic piglets with citrulline twice a day orally, the increase in pulmonary artery pressure and pulmonary vascular resistance that we see in the chronic hypoxic pigs is markedly reduced in the piglets that were treated twice a day with citrulline during their hypoxic exposure. And the amount of NO produced from the perfusate is markedly improved and equal to control levels, as is the exhaled NO. So here's one model of pulmonary hypertension caused by chronic hypoxia in which citrulline therapy reversed the manifestations of pulmonary artery hypertension. So we then got together, we were pretty excited by that, got together with Bernard Thibault, who has a rat model of hyperoxia-induced, call it BPD. It's a model in which rats are placed in 95% oxygen for 2 weeks, and then they're allowed to recover for another week. So during this period of rapid increase in vessel growth and septation of the airways, they're exposed to hyperoxia, and they develop a phenotype of the lung that looks very much like bronchopulmonary dysplasia. So we asked Bernard if he would try citrulline in this model. And so these newborn rats were given intraperitoneal citrulline twice daily. And what he showed is that the citrulline, so here's normoxia. You see a nice lacy pattern. Here's the mean linear intercept and a high septal count. Compared to the hyperoxic animals, over here, my pointer is dying, which have a much more simplified lung, a much higher mean linear intercept and lower septal count, consistent with arrest of alveolarization. And I think you can see in the hyperoxia plus citrulline group shown in this micrograph here and in the blue bars that citrulline improved the alveolarization of this lung and improved the septal counts. This is a model of wicked pulmonary hypertension as well. So the hyperoxic rats have marked thickening, as you can see, of their vascular wall. And you can see this quantified by the menial wall thickness, which is markedly elevated in the hyperoxic rats. And this was markedly reversed in the rats that were treated with the same hyperoxic exposure, but received L-citrulline during those 2 weeks of therapy. And also, as a measure of pulmonary hypertension, they looked at right ventricle compared to left ventricle plus septal ratio, again, a measure of right heart failure and pulmonary hypertension, showing that the hyperoxic rats had evidence of right heart dysfunction, and this was also improved with citrulline therapy. So now we've got 2 models, both of abnormal pulmonary vascular structure and function, that seem to have been responsive to citrulline therapy. But before you all run home and give all your babies with pulmonary hypertension citrulline, I'd like to offer a word of caution. So we did look at arginase 2 expression. So arginase 1 is the arginase enzyme in the liver. Arginase 2 is the enzyme expressed in the lung. And to our horror, we found that arginase 2 was increased in its protein expression with citrulline therapy. It was also increased with exposure to hyperoxia, and those two were synergistic with this dramatic increase in the protein expression of arginase 2, which might act on that arginine that is produced from the excess citrulline, resulting in adverse effects in the lung potentially. We were a little reassured when we measured arginase activity. So you can see arginase activity is markedly increased under hyperoxic conditions, but is normal under hyperoxic conditions plus L-citrulline. So the next step we need to do, and we haven't done it yet, is time course experiments, because I don't know which comes first, the chicken or the egg. I don't know if the protein is increased and then the enzyme is downregulated, or if citrulline downregulates enzyme activity, and as a result, protein levels are increased to maintain homeostasis. This is an important study that we need to do. But I think there's still potential harm to citrulline therapy, and we are now evaluating this in a NIH grant looking at metabolism of amino acids in our babies at risk for BPD, as well as in a grant in our piglet model to look at citrulline homeostasis. So to wrap this up and conclude on time, inhaled nitric oxide and surfactant are evidence-based therapies for the treatment of infants with PPHN. But not all infants will respond to these therapies. Approximately 40% of our babies fail to respond to vasodilator therapy. There are many supportive therapies for infants with PPHN that we use all the time, but are unstudied therapies and unproven therapies. And there's lots of opportunity for more research in this area. So I think high FiO2, automatically treating kids with pulmonary hypertension with 100% oxygen, may be a case in point. Alkaline therapy, which I'm not going to talk about unless you ask me questions about it, hyperventilation and sodium bicarbonate, which is not even written right, are another examples of unproven therapies that have been widely used in the past and I hope are decreasing currently. Sedation and paralysis, never studied. We have no idea whether it's helpful or harmful. My suggestion is, in most cases, particularly paralysis, is harmful. And then other vasodilator therapies, which are coming into vogue more and more. Sildenafil, see, I mentioned it twice. Magnesium sulfate, which I have no experience with, but again, anecdotal evidence, no big randomized controlled trials. And so my conclusions are that novel therapies are needed, and I think are on the horizon, and that we will see some introduction of new therapies, certainly in the practicing career of most people in the audience, hopefully before I retire, that may change the face of how we approach our infants with pulmonary hypertension. So thank you very much for your attention.
Is inhibition. I know, for example,